Good day. My presentation today is going to be on the nutritional management of type 1 diabetes in children, with some focus on the latest developments and recommendations. Diabetes is the third most common disease in children and adolescents aged less than 18 years. The most common age at diagnosis is between the ages of 4 to 6 years old, and then again between the ages of 10 to 14 years. Over the last couple of decades, there's been a rapid increase in the incidence of type 1 diabetes again in young adults aged 20 to 24 years old. The goal of diabetes management in children is to achieve near normoglycaemia without major hyperglycemic episodes, and it's also to prevent long-term complications that are associated with hyperglycemia. Achieving early normalization of blood sugars through intensive insulin therapy may enhance long-term control. Effective glycemic control in individuals with type 1 diabetes delays the onset of and decelerates the progression of chronic complications. Several approaches are taken when aiming for low glucose targets. However, intensive treatment dose does not just include intensive insulin regimes. It's important that healthy eating habits are established as early as possible. At the same time, children's mental wellness needs to be nurtured, and this is crucial for reaching diabetes treatment objectives and enhancing overall quality of life. So the key components crucial for achieving these objectives include diabetes self-management, education and support, medical nutrition therapy, regular physical activity, appropriate counseling for tobacco cessation if necessary, healthy behavior counseling, and psychosocial support. Diabetes self-management education and support, which also includes medical nutrition therapy and psychosocial support, must be provided at diagnosis and regularly thereafter. This should be done in a developmentally appropriate format that builds on prior knowledge, and it should be done by a team of healthcare professionals that are experienced with the biological, educational, nutritional, behavioral, and emotional needs of the growing child and family. According to the United Kingdom's National Institute for Healthcare and Excellence recommendations, children and young people with type 1 diabetes and their families or carers should receive a continuing program of education from diagnosis. And some of the topics that can be covered include insulin therapy, including its aims and how it works, how insulin works, topics on insulin delivery, including rotation injection sites within the same body region and dosage adjustment. Another topic is blood glucose monitoring, which includes blood glucose itself and monitoring of the HbA1c targets. The next topic is the influence of diet, physical activity, and illness, and how these affect blood glucose levels. Focus should also be given on the management of illnesses, particularly what parents and children should do on those sick days, including monitoring of blood ketones. Lastly, the focus should also be placed on detecting and managing hypoglycemia, hyperglycemia, and ketosis. Management of type 1 diabetes is specialized, and such health professionals should consider the unique aspects of care and management of children and adolescents with type 1 diabetes, such as changes in insulin sensitivity related to physical growth and sexual maturation, the ability to provide self-care, supervision in the childcare and school environment, neurological vulnerability to hypoglycemia and hyperglycemia in young children, and possible adverse neurocognitive effects of diabetic ketoacidosis. Treatment should be tailored to each child or young person with type 1 diabetes and their families or carers. And one should always take into account issues such as the physiological differences that are related to the different developmental stages that children are, That means that children at birth or at 2 years old compared to children that are going through puberty and older adolescents have different developmental needs. We should also focus on the family dynamics. Personal preferences are important, emotional well-being, cultural considerations, particularly in our African settings, existing knowledge, and what the family's life goals are. Next, we're going to look at the medical nutrition therapy and some recommendations around that. So nutrition therapy assumes a pivotal role in comprehensive diabetes management strategies. It's essential to recognize that there is no universally applicable eating pattern for diabetes. So it's very important that meal planning is personalized according to individual needs. Dietary recommendations for young people are also based on population healthy eating recommendations. And so you'll see with the specific macro and micronutrient recommendations that it tends to be according to general healthy eating recommendations. Very important, and again, emphasizing our African circumstances, that consideration should be given to the presence of food insecurity. Nutritional advice must be adapted to cultural, ethnic, and family traditions and the psychosocial needs of the individual young person. Education can be delivered both to the child or young person and family, or alternatively, small group settings can also be considered. However, it's very important that the whole family is involved in ensuring that appropriate changes are made according to the healthy eating principles. The dietitian should be available wherever possible as part of a pediatric multidisciplinary diabetes care team to provide education, monitoring, and support to the young person with diabetes. The dietitian should emphasize and advise on planning, the content and the timing of snacks and meals in the context of each child's individual circumstances. We also need to consider the child's lifestyles and also the insulin action profile of the prescribed regimen. Education should also include behavior change approaches, motivational interviewing and/or counseling, and it should be reviewed regularly to meet the constantly changing needs of the developing child, as we know that children go through different phases in their lives. Next, we look at the specific energy and nutrient recommendations for children with type 1 diabetes. With regards to energy, we all know that energy requirements in young people must be individually tailored to an eating plan that is achievable and also nutritionally adequate. Young people living with food insecurity should be offered strategies to alleviate the challenges and stresses that may be experienced, which make achieving dietary recommendations for diabetes very difficult. And this is again particularly true for our African context. Regular dietary reviews also help families understand how to adjust total energy intakes with changes in age and stage of development to promote optimal growth and avoid restrictive diets or overnutrition that can lead to excess weight gain. These are specific energy requirements for children by age. Total energy intake is based on the child's age and gender. And appetite can significantly affect the overall intake of a child. It's an important time to consider when a child is hitting puberty and to actually make sure that the recommendations are adhered to in order to prevent deficiencies or energy deficiencies. With regards to carbohydrates, carbohydrates and the achievement of are important in the achievement of optimal postprandial glycemic targets, and these have to be appropriately matched to insulin. So the insulin to carbohydrate ratio is very important to balance. There's a lot of debate surrounding carbohydrate intake, whether to recommend low carbohydrate diets I mean, at what age should low carbohydrate diets be recommended and whatnot. However, scientific evidence is lacking to support the practice of very low carbohydrate diets or excessive carbohydrate restriction in young people with type 1 diabetes. Strict adherence to very low carbohydrate diets may result in ketonemia or ketosis, sometimes dyslipidemia and disordered eating behaviors, which are quite a risk at this in children. There's also evidence from ketogenic diets that very low carbohydrate diets can be nutritionally inadequate and therefore may result in growth failure. The recommendations for carbohydrates are displayed on the slides. So the recommendations range from 40 to 65% of total energy, and these are this will be something that is calculated by the dietitian. Whether or not the carbohydrate restriction is associated with better health outcomes, again, remember that is still not certain, and so an individualized approach is always recommended. Important to note that sucrose can make up to 10% of total energy intake. And so that can either be included in the total carbohydrate recommendations or calculated separately. Specifically focusing on sucrose. So researchers demonstrated over and over again that sucrose does not increase glycemia more than isocaloric amounts of starch. Sucrose and sucrose-containing foods and fruits should be consumed in the context of a healthy diet, however. And the consumption of foods containing added sugar or sucrose should be minimized to avoid displacing nutrient-dense food choices and decreasing dietary quality. So if sugar is added or sucrose is added, it should be appropriately balanced against insulin doses. Sugar-sweetened beverage consumption has been associated with excess weight gain. Large amounts of these sugary beverages also causes high postprandial glucose peaks, and these are difficult to adequately cover with insulin. The consumption of sweetened cold drinks and soft drinks and cordials should therefore be discouraged for the whole family. And we know that this is really quite one of the challenges that faces us all today. Reported fiber intakes are often lower than recommended, and these vary geographically, but they're even lower in children. Dietary fiber is associated with digestive health and modulates bowel function, fermentation, and has effect on gut microbiota. Diets that are high in whole grains may help to improve satiety, replace more energy-dense foods, and they prevent weight gain. So increasing fiber intake can assist in improving glycemic outcomes and reducing cardiovascular disease risk. Studies show that young people with diabetes tend to consume fats and saturated fats, particularly above recommendations. Children should consume a healthy diet which limits these saturated fats. And we should rather have higher amounts of polyunsaturated and monounsaturated fats to reduce later cardiovascular risk. With regards to specific recommendations of the poly and monounsaturated fats, these are the same for the adult population. However, when looking at the total percentage of total energy, the fat recommendations are also indicated, and that they range from 30 to 40% of total energy that should be consumed per day, depending on the child's age, level of development, and levels of physical activity. Protein intake decreases during childhood and adolescence from approximately 2 grams per kilogram per day in early infancy to 1 gram per kilogram per day for a 10-year-old child, and up to 0.8 to 0.9 grams per kilogram per day is the recommendation in later adolescence, and that is more closer to the adult recommendations. Vitamins, minerals, and antioxidants. Young people with diabetes have the same vitamin and mineral recommendations as other healthy peers. There is no clear evidence of benefits from vitamin or mineral supplementation in children and adolescents with diabetes. especially those that don't have underlying deficiencies. So what's important here is to encourage parents to ensure that their food choices are optimal and that their recommendations are made through food rather than through dietary supplementation or through supplements. Sodium. The guidelines for sodium intake in children 1 to 3 years is 100 milligrams per day. That's about a half a teaspoon of salt per day. For children aged 4 to 8 years, that's about 3 grams of salt per day. And for children 9 years and older, about 3.8 grams per day. So under a teaspoon a day that is recommended of salt for children to be consuming. And it is, I'm sure if we all go and look, a lot of our children are also consuming excessive amounts of sodium. So a little bit of a focus on other considerations in type 1 diabetes management, which as healthcare professionals, we need to take cognizance of. So firstly, we look at the influence on parents. So one can think that following their child's type 1 diagnosis, parents typically are the ones that are responsible for overseeing all aspects of their child's management and regimen. And this comes with a lot of responsibility, and some parents tend to experience a lot of diabetes-related distress. There's a negative emotional response to the burdens of managing their children's diabetes regimen during the initial months following their child's diagnosis and beyond. And one can just think as a parent how frightening it might be to think about what happens if I get this wrong. So these are just some of the burdens that have been found in a research study where parents reported what their burdens are in managing their children or living with their children with type 1 diabetes. So some of the burdens were worry about low blood sugar, worrying about future complications, feeling upset when diabetes management is off track, and the negative impact on sleep quality and quantity, with parents having possibly to get up at night to check on children. And these burdens can have a negative impact on both family functioning, as well as on the individual parent and their social functioning. So where possible, parents should also be assisted with referrals for management of the psychosocial aspects of managing their children. Psychosocial functioning in the actual child that's living with type 1 diabetes. At diagnosis and during follow-up care, children that have type 1 diabetes need to be screened for some psychosocial concerns. And sometimes this is not really, not a lot of attention is paid on this. But as healthcare professionals, we should also have on hand psychologists, preferably those that specialize with working with children that have type 1 diabetes. So these are just some of the factors that can be screened for. We can also need to screen, or we should actually also screen for food security. Other than that, we also need to screen for factors such as housing stability and children that are homeless. We need to look at the health literacy of our children and of their families just to see whether they understand what the implications of their healthcare is, look at financial barriers, and also investigate whether there is a need for social or community support. And where possible, we need to find resources for children and their families to be supported. Food insecurity is an important social determinant of health, particularly in our developing countries, as we experience some of the highest rates of food insecurity. And the impact of food insecurity has been much higher in young people and adults with type 1 diabetes than those without type 1 diabetes. And food insecurity increases the risk of a less diverse diet, and often the diets are lower in quality. And so this leads to reduced micronutrient intake, iron deficiency anemia, and overall intake of low intake of fruit and vegetables. We all know that adhering to any dietary recommendations or any meal plan is difficult. And we find it quite often as dietitians that our clients tend to know what they should do, but they don't always follow the eating patterns or meal plans that are prepared for them. And this is the same for parents and children, for parents with children that have type 1 diabetes, and also for the children themselves. So some of the challenges that have been identified in feeding children with type 1 diabetes a healthy diet has included cost and availability of healthy foods. I cannot stress this enough. The number of times where patients have come and said, the diet that has been prescribed for me is way too expensive and we cannot manage this diet as a family. It's something that as dietitians and health professionals, we have to be careful about. Picky eating tendencies in young children, the desire to maintain the same food options as siblings and peers. And so we need to come up with a way where the whole family is on board with whatever the meal pattern is, so that there isn't a distinction between the child that has type 1 diabetes compared to their siblings and so forth. And there's also difficulties in getting younger children to try new foods. Then we come to physical activity and some of the recommendations surrounding that. And we know very well that physical activity is very important, and it is very well known that it positively impacts metabolic and psychological health in children with type 1 diabetes. Important that the effect is not only on metabolic functioning, but also on the psychological health. Children and adolescents with type 1 diabetes, the recommendation for physical activity per day is at least an hour a day of moderate or vigorous intensity aerobic activity per day. Achieving this could be challenging because of disruptions in, physical activity and having to manage insulin. So the responses to exercise and the children's inability to adjust their insulin in response to changes in glycemia can also present a challenge. There needs to be frequent glucose monitoring before, during, and after exercise. And different methods can be used, and we know it depends on the context whether the continuous glucose monitoring and the other more technologically advanced monitoring systems are afforded or not. But it's still important that glucose monitoring is done, and this will help to prevent, to detect, and to treat hypo and hyperglycemia that's associated with exercise. Blood glucose goals should be individualized, and these are based on the type, intensity, and duration of activity. And this is really something that really requires specialized attention. Not everyone can do this. Additional carbohydrate intake should be considered during and or after exercise. And again, this depends on the intensity and the duration of the physical activity. So in advising parents on how they can manage blood glucose levels and carbohydrate and insulin during physical activities, so these are just some of the recommendations that can be given. So some advice that can be given. One, parents should be encouraged to check that the starting glucose level must be interpreted in the context of the timing of any pre-exercise food and insulin. And I really think parents that are unsure of this should work closely with a dietitian so that they know if the child participates in this type of exercise and the duration is this long and my child is going to be on the field this long, that there's a clear understanding of the possible requirements surrounding blood glucose control, carbohydrate intake, and insulin control. So blood glucose levels should also be about 5 millimoles per liter at the beginning of activity. During exercise, the recommendation is between 5 to 10, though some authors recommend 7 to 10 millimoles during exercise. And then a blood glucose should be checked at least 2 times, or actually an hour before the activity, 2 times, an hour before the activity, then every 30 minutes during and immediately after the activity. Lastly, blood glucose should then again be checked 1 to 2 hours overnight, particularly if activity was strenuous. But if the activity was not strenuous, then it's not necessary to check it that frequently. But again, one needs to really see in the beginning how a child reacts, and that will determine the frequency of blood glucose checking and so forth. So I tried to sort of explain how exercise might influence blood glucose, and I found this wonderful explanation in one of our textbooks that says that usual glucose responses in type 1 diabetes should be tailored according to the type of activity, whether it is aerobic, mixed types of activity, or anaerobic. And as you see in this figure, blood glucose rises or falls depending on the type of activity. So in aerobic activity, blood glucose tends to fall. So this is walking, jogging, and cycling. During exercise, blood glucose tends to fall. And then in mixed activities, it may rise or fall. And in anaerobic activity, blood glucose levels tend to rise. Yeah. Right, so a little bit more specificity with regards to carbohydrate intake during and before and post exercise. So most aerobic activity lasting more than 30 minutes will need an additional carbohydrate if insulin has not been adjusted. Carbohydrates and proteins should be consumed before the planned activity lasting, particularly if the activity lasts more than an hour. And for many children, 10 to 15 grams of carbohydrates will be enough to prevent hypoglycemia. If the exercise intensity was high or strenuous or anaerobic, then additional pre-exercise carbohydrate may necessitate a bolus insulin. So there again, the parents might need to just check with the child in their blood glucose levels pre-exercise. Hypoglycemia will occur during exercise if insufficient insulin was available, particularly if the exercise was anaerobic. Brief high-intensity anaerobic exercise such as sprinting if it's brief as in less than an hour, this may not necessitate a carbohydrate intake before exercise. However, what tends to happen is that there might be a dramatic fall of blood glucose immediately after exercise during muscle recovery. If this is the case, hypoglycemia can then be prevented by taking additional carbohydrates, about 15 grams of carbohydrates after sports or immediately after the sporting activity. Following moderate or intense exercise of 45 minutes or more, carbohydrate stores must be replenished to lower the risk of hypoglycemia, as insulin sensitivity remains raised for several hours post-exercise. So post-exercise hypoglycemia can be minimized by the consumption of low glycemic index foods and eating protein foods or otherwise reducing basal insulin. Another alternative is that lower than usual bolus dose of insulin can be taken post-exercise. And again, I want to emphasize that parents really need to work closely with their health professionals in order to manage this, because as you can see, it does get quite complicated. So during cool down, hyperglycemia is actually hypoglycemia is quite common. And a potential cause of this is the production of lactate during exercise, which is not removed at the end of activity by an active cool down. So introducing 10 minutes of cool down exercise at the end of the activity can reduce the post-activity high. It's supposed to be hyperglycemia. My apologies about that. So in conclusion, at the end of it all, children and youth with diabetes should receive age and developmentally appropriate pediatric care. So other than just medical nutrition therapy and insulin therapy, those children that need to be receiving their vaccines and immunizations, that should still be adhered to. Additionally, all health professionals should refer people with diabetes, particularly children as well, for individualized medical nutrition therapy. And this should be provided by a registered dietitian that is knowledgeable and skilled in providing diabetes-specific medical nutrition therapy. That is the end of my presentation, and I look forward to your questions. Thank you.